start. Good morning, I'm Cheryl Neverson. I am the Vice President for Maryland programs with Volunteers of America, Chesapeake and the Carolina, but I'm also a co-chair of a subcommittee here with talking about behavioral health and integration, co-chair with Scott. Scott, do you want to introduce yourself?
Sure. Good morning, everybody. Scott Showalter. I'm the mental health coordinator for PGCPS. Thank you for being here with us.
Yes. So thank you. Just a little bit about, before we jump into our presentation, just a little bit about this subcommittee. This is a subcommittee for Prince George's County Healthcare Action Coalition, which is a behavioral health advisory group for Prince George's County. And it's made up of people, administrators, leaders in Prince George's County to come together as one to talk about care across the continuum for residents of Prince George's County. This particular subcommittee is working to promote integration of behavioral health and somatic care among providers, community programs, and schools in Prince George's County. This committee has endorsed the framework that we're going to talk about, which is a standard framework for levels of integrated healthcare, which allows primary and behavioral healthcare providers to understand where they are with integration along this continuum. I'll present Bree Ryman. Bree, did I pronounce your last name correctly?
You did, thank you.
She's the Assistant Vice President at the National Council for WellBeing, and she's a leader in integrated health. And as well, she's headed up the SAMHSA HRSA Center for Integrated Health Solutions. And she was involved with the creation of this particular framework that she's going to talk about today. And just a little bit as a background, in April of 2013, the SAMHSA HRSA Center for Integrated Health Solutions released a report that demonstrated how the integration of healthcare is essential to improve an individual's experience of care, to improve the health of the general population, and to reduce the per capita healthcare costs. So we do see that this type of model does work. And the issue brief reviewed levels of integrated healthcare and proposed a functional standard framework for classifying sites according to these levels. And so Bree will provide a background on the development of that framework. She will discuss how to best use this framework and some current updates that have been made. So if we can go, just before Bree, you come on, we just want to welcome you. People, again, if you didn't do so already, just write your name and the organization that you're from in the chat so we can keep that for our logs. And so without further ado, I'm going to turn it over to you, Bree, so you can go ahead and talk to us a little bit about levels of integrated healthcare.
Morning, everyone. I have a little bit of a raspy voice this morning. I'm still in Colorado, so we're in the early hours still. The sun's just coming up. I hope that the weather is beautiful where you're at. I spent several years in DC and really enjoyed being out there, and just recently came back to my hometown. And I would love to hear, if we could hear from a couple people, if that's okay, just around what you're hoping to achieve or learn about the framework. I understand, and as you understand, it's a tool to help you kind of measure where you're at with your integrated care progress. But I would just love to hear if there's any questions or anything you want to make sure that I cover as part of the session. That would be great. I love these to be interactive, so I'm not the only one talking. And you can chat it if that's easier too. Still early.
Bree, I go first. I know I'm the co-chair, but I'm really excited to learn more about levels of, of integrated care. At Volunteers of America, we were awarded in 2020 a SAMHSA grant for CCBHC. And we
Congratulations.
Thank you. And we were recently awarded another SAMHSA grant for Community Mental Health Center. And so I want to use both of these to really work with our agency, which we've been doing for the past year, on how to figure out where we are on the continuum and how to move forward. I think one of the biggest challenges for us has been just the change management and really getting everyone to buy in. And it's coming up, it's really getting there, but it takes a lot of time. So I don't know if you have any advice when you talk about this, how to get, everyone moving in the same direction.
Yeah, that's one of the biggest challenges. So happy to share some lessons learned there.
Good morning. My name is Michael Hunter. I'm interested in finding out more about what types of technologies you're seeing put in place to document evidence-based practices.
Yeah, that's a good one too. I think we're seeing a lot of new innovation around electronic use of different tools, just given the pandemic and how care has changed over the past, now almost 2 years. So that digital innovation piece. And I am just starting to get much more familiar with that with my work with the CCBHC. So thank you for that question. I'll share what I know.
Thank you.
Hi, I'm Barbara Banks Wiggins with the Prince George's Healthcare Alliance. And we are about to embark on a huge community health worker grant with the health department. And the vision of our health officer is to integrate community health workers into several different providers and health systems. And I'm just interested in learning about how the different roles that people play in the integrated healthcare. And I'll be listening to see how community health workers can integrate into the behavioral health provider space.
Great. I think we can
That's
talk a lot about
social determinants of health. That's mainly to focus on social determinants of health barriers and helping people overcome them.
Got it. All right. Well, this is very helpful. And please, if I didn't hear from you and you have something that you want to put it in the chat box, that would be great as well. So I'm glad to be here. Again, I'm Bree Ryman, Assistant Vice President with the Practice Improvement and Consulting Department at the National Council for Mental Wellbeing. Next slide. So if you're not familiar with the National Council for Mental Wellbeing, we work to drive policy and social change on behalf of our members. Our members are just around 3,500 mental health and substance use treatment organizations that serve 10 million children, adults, and families across the country. We work to advocate for policies to ensure access to quality healthcare services. And along those lines, we also, in my department, we provide, we have about 62 initiatives in the PIC department, the Practice Improvement and Consulting Department. And our work focuses on quality improvement around integrated care, but also just overall enhancing community mental health and substance use services. We work with public health officials, primary care providers, behavioral health providers as part of our membership. We work with state associations, policymakers, and really all of the work under our umbrella is really to increase access to quality mental health and substance use services. Access for everybody, regardless of the community that you live in. And, I'm so glad I heard already about CCBHCs because that's one of our primary missions now is to advance CCBHCs across the country so that there is a CCBHC in every country. And I have a couple slides to talk about kind of how far we've come with that initiative. It was the National Council that really planted the seed for CCBHCs at the levels of Congress, and then helped to advance the integration and implementation of CCBHCs. And if you know a lot about SAMHSA grants, you'll know that the CCBHCs basically have evolved from one of the first initiatives that SAMHSA funded, which was the PGHCI grantees, so the primary behavioral healthcare integration grantees. So SAMHSA, well, and even before that, there were expert grantees. That's where I started my career in the early 2000s. I was a coordinator, a manager, and a director, all within the same bucket of work. Over 10 years, I integrated screening, brief intervention, referral to treatment into hospitals and primary care and HIV settings in Colorado. And that was 10 years of funding. And then the work kind of evolved. So SAMHSA funded these expert initiatives around that really focused on integration. Then they moved to fund the PGHCI grantees, those primary behavioral healthcare integration grantees. And that was kind of a broader umbrella of integrated care, working with both behavioral health and primary care organizations. And then we saw the PIPIC grantees, or the promoting integrated behavioral health and primary care. It was basically the same acronym, but it funded, rather than funding clinics directly, SAMHSA decided to fund states so that states could advocate for comprehensive integration across the state landscape. And now we see CCBHCs, the Certified Community Behavioral Health Clinic demonstration, which is, again, it's just SAMHSA's evolved, and that, the landscape's evolved. We're focusing more on social determinants of health, diversity, equity, inclusion. We just have transformed the way that we're looking at integration. And I think it's a really exciting time to be in the field, although also really challenging. I don't know if you had a chance to, I'll make sure you get a link to the survey that the National Council just launched through Morning Consult. We had just about 300 respondents to a survey that just talked about really the impact of COVID-19 and kind of where we're at with retention, recruitment. We have providers who are losing, their mental health staff to Starbucks and McDonald's, and because they just can't keep up with the wages that are paying a living wage at all. So we have a lot of work to do in the policy and advocacy space, as well as in taking care of our workforce, so that we can continue to care for the people that need it most. So there's a lot going on. That was just a little bit of a history to share kind of where I'm coming from, but also where I think some of the policy priorities, SAMHSA, HRSA, the government funding is kind of wrapping around. We're seeing a lot of CCBHCs also become FQHCs, and I think, to me, as somebody who's like an integration champion, I think that the reason why a lot of these CCBHCs are also now applying for FQHC funding is so that they can do more comprehensive integration work. So there's a lot of innovation out there in pockets that we just need to learn from. Next slide, please. And we did recently rebrand. So we were the National Council for Behavioral Health. That's right. Anyways, but now I appreciate our name much more now, because I think it's much more comprehensive in terms of the work that we do and the work that we need to do in this space. I'm so glad I heard about the social determinants of health. I mean, we can no longer do care without addressing health and really wrapping around that support and thinking about models like team-based care and the community health workers involved in that, and peer specialists, and how do we lift up peer support providers to be part of this model of care, people with lived experience who can really speak to the issues that a lot of our individuals are facing. So I'll talk a little bit about integration and kind of where I'm coming out from the lens of integrated care. I'll talk about the SAMHSA levels of integration, the IPAT tool, which was the tool that was developed to help. I think it's a good tool for you all to look at if you haven't had a chance. It's the integrated practice assessment tool. It was developed as a kind of a step 2 of the levels of integration, as a tool to really easily sort of assess where you're at in the levels of integration, and then as a tool to help you develop some goals around where you want to be with integration. And then I'd really love to share something I'm very excited about, is the General Health Integration Framework. This is a tool that was developed by Dr. Henry Chung at Montefiore in New York. And I think it is, it's almost like the next phase, sort of how I talked about the evolution of SAMHSA funding and integration out in the world. The GHI framework is almost a more comprehensive tool than the levels of integration. I think they can all be used together to provide really meaningful information, but I think it's a good tool to discuss as well as part of this dialogue. We have at the National Council with the GHI Framework, we're working on, we have a Medical Directors Institute that's comprised of about 35 medical directors, psychiatrists mostly, but I'm working to include more primary care and family medicine in that group. It's a really diverse and nationally represented council, and they're working to develop a tool that goes alongside the GHI framework so that it's just practical, easy, accessible. So I'll make sure that you have all this information so that you can really look at all these tools and find out what works for you. What we found with the levels of integration, and I'm jumping ahead a little bit, but I think it's important, and the iPad tool even, is that people felt really like they were being, organizations like the teams, that they were being put in boxes. Like you had to do a certain thing to be successful at integration. And the case is that integration looks different for every organization, every community. We used to think co-location was not quite as good as full integration, but that's not the case. You can be a co-located provider, have really strong partners in the community, comprehensive team-based approaches to care, and not ever be fully integrated and still have a lot of success. It's more about the success of the partnerships, the success of the models that you're integrating in terms of that evidence-based models and practices that you're implementing, and less about achieving full integration, that level 6 on the levels of integration, which we'll talk about. Next slide, please. So I'm just going to talk a little bit about where I come from in terms of my definition for integrated care and kind of how I conceptualize integrated care in my work. So it includes a practice team of primary care and mental health and addiction providers that work together alongside each other as a comprehensive care team. Again, they don't have to live under the same roof. They don't have to, they can be, I work in a lot of rural communities in Colorado, or I did for a number of years. And that was just never a possibility for the communities that worked with migrant farm workers and some of our HIV care providers. And so that partnership piece was really how they achieved success with integration. So it sort of looks different in each of the communities, urban, rural, frontier, that's available, and the resources that are available. It's systematic and cost effective. So really one of the goals with integrated care is that it may cost more money up front. However, the long-term goal is that you're offering more prevention, early intervention. So it does become a more cost-effective model than sort of separated care, and really you're working toward reducing things like hospital visits and emergency rooms. You'll see that in the CCBHC care model. One of the primary goals is to reduce unnecessary use of emergency services, and we're seeing that with some of the crisis services that CCBHCs are required to provide. Patient or person-centered care. So really the person is at the center of all the care. I think that this is pretty prominent in some of the evidence-based care approaches that we see, like motivational interviewing and some of the core elements of integrated care really puts the person at the center. And that involves some work for people because it's really empowering the person or the patient or the client to be sort of the center of their care and their own personal advocate. And then we're kind of wrapping around that client to provide the best services that we can based on their lived experience, based on their family history, where they live, where they access food, all of those things that we have to think about, their access to transportation, all of the social determinants of health that we talked about as well. And do you all use patient or client as your language? I always try to match the language that you use. Or do you use different language?
I can only speak for myself. I generally refer to them as patients, but that's right.
Okay.
Speaks
Patients.
to my hospital-based background. That's
I grew up
in my head, right?
Yeah, I grew up in the primary care space too, so I usually say patient as well, but I'm also mindful that not everybody likes that term, so I'll do my best to accommodate, and just call me out if I'm offending anyone, okay? There's a defined population, consumer. Yep, I see that. I like consumer too. We'll say people today. I'll try to say that. How's that? Or individuals. A defined population. So this is debatable. So I'll give you an example. In my work in Espert for a number of years here, we had targeted primary care sites. Our goal was to, achieve state-based. Every primary care provider was asking these evidence-based screening questions for alcohol use. There was a standard model of care. And what we found over a number of years that was like pie in the sky goal. Like there was no way that we were going to achieve every primary care provider, nurse practitioner was going to do this. We've made a lot of success, and I'm happy to say that Espert is still happening in Colorado after several years of the end of the SANSA grant. However, what we noticed maybe in year 3 or 4 of a 10-year cycle of grant funding is that we really should start to focus on a defined population and then grow the model. What are the lessons we can learn, for example, with screening only in HIV settings with individuals who have co-occurring disorders? Let's refine that model and take the lessons learned and improve upon what we know, and then grow the model into other areas. So then we started screening in HIV clinics in hospital settings. Or what can we learn in one rural clinic that we can then apply to another rural clinic? We have if you've been to Colorado, it's pretty mountainous on the western slope. I worked a lot with migrant farm workers, and a lot of it was, they weren't accessing care in a clinic. We had to go to their homes. So how do we adapt a model and make it work for the people that are living in that community? So I think the other lesson learned with, through my integration work is that you likely will have to make some changes with your approach. And I think, that's okay. That's how we enhance the service delivery and just the model overall. We also were, identifying champions that really could help to champion integration across all of our communities. And that was really one of our key success areas, is identifying those champions, the people that understood the model and why it was important, and then helping to sort of grow the model in community process. And then the care includes mental health, substance use, that includes trauma-informed care, and addressing the social determinants of health, of course. And I think that trauma-informed lens is really critically important. I think we can assume that that's being done, but in reality, that's not always the case. So really adopting trauma-informed policies, training for your providers and community members around trauma-informed care, and also the impact of trauma on health and well-being. What does that look like, and how do we have conversations around trauma and things like adverse child experiences, because it certainly does have an impact on health and well-being. Next slide, please. Realizing how orange everything is now with our new branding. And did you all notice that? Like, we used to be blue, so this orange is like, takes some getting used to. So the core elements or core components, I'd like to say, of integrated care, it includes, being responsive to community needs. And again, I think that also includes being adaptable to the community and population needs that you're working in. Acknowledging the social determinants of health in all steps of care, planning, and delivery is really critically important, because without addressing those other core elements of a person's story, really achieving health and well-being is not really possible. Again, I think we learned a lot about that in many of these grant cycles, where I'm sure many of you have had SAMHSA funding. It's very targeted at like achieving GIPRA data and SPARS data and all these administrative things, but really you have to sort of figure out ways to grow beyond those requirements, those grant requirements, and really address, a bigger picture, especially as you think about sustainability beyond the grant cycles. And I think that's really challenging, because for a lot of history, we have supported mental health and substance use services through these grant initiatives that end. There's always an end date, and then what happens after that. So, thinking about that sustainability piece early on and figuring out how to address beyond those grant cycles is important. Establishing robust and thorough screening. So, you know, we've had a lot of experience with screening, things like screening for substance use, screening for depression, and really adopting the evidence-based approaches with those screening. So adopting an evidence-based screening tool like the audit or the PHQ-9, and then offering brief interventions and motivational interviewing that really is rooted in the evidence base. There are these evidence-based practices that can really promote, you know, the advancement of integration if adopted correctly. The inclusion of medication-assisted treatment as a service option for individuals who need that and who need access. So having access to MAT providers in the community, again, part of that comprehensive approach and meeting individuals where they're at in their care. And so having access to MAT services. The organizational culture piece, so I think that came up earlier. How do you, this change management piece and adopting strategies that help with that change management, leadership buy-in, developing policies and procedures that support integration are really important for sustainability. The availability of telehealth and telebehavioral health. So we've seen a lot of change with the policies within the past couple of years related to the pandemic and making telehealth more accessible to individuals. This is great in terms of you know, our long-term success with being able to provide telehealth services to folks. Now we're working at the National Council to make sure that policies stay and remain post-pandemic to support access to telehealth and telebehavioral services. And we've seen a lot of really interesting and unique success and innovation around telehealth, and also thinking about digital equity and accessibility to some of these resources is really important, as well as you consider telehealth models. Participating in a drug monitoring program, so really thinking about that prescription medication piece, tools like the prescription drug monitoring work, and you know, making sure that there's policies in place around PDMP programs. And then again, I think I mentioned this, understanding that adjustment, adaptation, refinement is needed along the way as it relates to integration. Next slide, please. I have children just waking up, so if you hear them, that's just them getting ready for school. They might pop in and say hi. My world these days. So integrated care in practice, what does it look like in terms of when you're adopting integration? Again, it looks different for everyone. I talked about the routine screening for common conditions and using evidence-based tools to do that. Engagement with care team trained in both addressing primary care as well as mental health and substance use. Interventions that promote healthy behaviors, thinking about what the population you're working with, and then integrating interventions that adequately meet the populations that you're working with, and also thinking about the team that you're working with, whether or not that's, you know, primary care and a behavioral team, but all those community members, law enforcement, you know, how is the community embracing integration, and are there adequate providers that meet the population needs? That also is looking at the diversity piece. Do you have providers that can speak the same language as the people that you're working with the history that might be needed to address certain cultural issues and backgrounds? So really important to think about your population interventions and how they match the environment that you're working in. Coordination with specialty care. So you've probably learned that not everybody needs specialty treatment, substance use treatment, for example. However, making sure that that's available if you do need to make a referral from one of your sites or organizations, and that there's strong referral mechanisms in place. What is the success of your referrals? If you do need to refer somebody to specialty treatment, for example, are they making it to that first appointment? Are they matching up with providers that meet their needs? So really looking into to that and seeing if those processes are in place and are well equipped to meet the needs of the population you're working with. Measuring the progress of both types of conditions of both, all mental health, substance use, the social determinants of health, as well as the primary care? Are you measuring the progress of your implementation around evidence-based practices, the advancement of the implementation of these tools, and revising as needed? That also includes the data tracking and care coordination piece. I think that's also where the community health workers play a critical role with that care coordination piece. Central to the care coordination that's needed around the population health clients you're working with. And then facilitation of patient activation and connection to natural supports, things like family, church, spiritual interventions, things that you can partner with, external community partners to really, again, wrap around the individuals that need support and care that you're providing. Next slide, please. We're getting into the tools now. I won't speak too much to the barriers. I'm sure you know the barriers, early adoption, community champions, making sure you have those, addressing this competing priorities issues, which is like more so ever now than it was before, helping people prioritize where the focus areas are and why integration is more critically important now than it ever was before. Needing to establish the culture, making sure you have the data tracking in place, addressing the stigma, and really making sure that there's parity. So parity between how we think about mental health and addiction, as well as similarly to how we address, physical health issues. So I know that just seems like, oh, right, we've achieved parity, but we really have a long way to go. There's still a huge divide between physical health issues and those mental health and substance use issues. And so trying to close that gap. Next slide. And we're seeing, quite frankly, that with the survey I mentioned earlier, that a lot of our mental health and substance use organizations are having to close their doors because they can't find the workforce. There's no workforce pipeline anymore for mental health services, and this is a huge issue. So now we'll get to the tools, which is the fun part. So again, like a little bit of history, this is how the levels of integration developed. There was initially this 5 levels of, or the 4-quadrant model that really helped organizations understand where they are on the 4-quadrant model, we'll just say. Again, this was in the early 90s. It was a great tool for initially thinking about integration, but again, it didn't address sort of all the needs. That was the feedback we got from providers. And so the way this tool works, and I still think there's good information in this. If you look at quadrant 1, the bottom left, if your organization or your community of organizations were serving a population that had low behavioral health needs and low primary health needs or physical health needs, then there's minimal collaboration needed between primary health and primary care and behavioral health. Now we know that that's not the case anymore. We still want to see collaboration across these providers for prevention, early intervention, and also just from a population health perspective. If you look at the level 2, which is the quadrant above the level 1 on the top left, basically this looked, if you have a population with high behavioral health needs and low physical health needs, basic collaboration or co-occurring or co-located care at a distance could help to support these individuals. So my issue with this, and I think the field's issue with this, is that it's very rigid, and you're not ever going to look at being provided care to an individual and say, which quadrant does this person fall? And then like cycling back to figure out, like, it's too rigid of a model and an approach, because there could be somebody who cycles across all of these quadrants and may require different elements that you see outlined here. So if you go to the next slide, this evolved into the 6 levels of integrated care, which is what we're really here to talk about today as a tool. The strengths of the levels of integrated care, the SAMHSA 6 levels of integrated care, is it built on the Doherty model. So it worked to really revise those 4 quadrants to a more population health-based tool. It provides organizations ideas to consider, And it has components that move towards better outcomes, which is, in this case, with the levels of integrated care, the goal is to get to a level 6, which is a fully integrated care model. I talked about some of the challenges with that a little bit earlier, and I'll get into that again. Some of the opportunities that exist with the tool, the levels primarily focus on the location and the team interaction. So it doesn't quite get at the surrounding community providers, this team-based approach. It doesn't talk about peer specialists. It doesn't address community health workers. It doesn't look at all these other things that we know work in terms of this population health integration piece. And again, I think these tools just will continue to need adapting as our kind of the needs of our population continue to adapt. So it's no surprise. It's very linear, so it needs the field reflected, and there was a lot of response around it just needing a more diversified approach, a sort of bigger lens, if you will, to focus on individual community needs and population needs. And the field's really moved forward with new research and new challenges as we have seen with the pandemic. And so I think there's just different tools that also are needed to help to advance the field. Next slide, please. So this is a really blurry slide, so don't worry too much. I'm sure you've seen this, but I'll just talk you through a little bit how organizations have used this tool. So if you remember in the Doherty model, there's these 4 quadrants. This evolved to now include six quadrants, if you will, or 6 levels, if you will. So the levels 1 and 2 in the coordinated indicate a coordinated model of care. So minimal collaboration between, in this case, behavioral health and primary care providers. Again, we're missing all those other important providers that are needed in an integrated care model. Level 2 is basic collaboration at a distance, so kind of a co-located model. And if you were in a level 1 where there's minimal collaboration, what that means is that, and you could branch out and say this includes other organizations. You could adapt it the way you think about this tool based on your environment and what you're trying to achieve. So it basically says at a level 1 that organizations are working in separate facilities where they have separate systems altogether, documented, EMRs, things like that. They communicate across or about cases rarely and under competing circumstances. So it's not quite a priority to communicate on a person's care plan because of other competing priorities. The communication is driven by provider need rather than patient or client need. And the providers may never meet in person. And obviously there are issues with that, right? Because you have to develop, as I mentioned before, these partnerships, these strong referral mechanisms so that people are getting the care that they need. And there may be limited understanding of each other's role in this model. So obviously, it sounds like you all are much more advanced than that minimal collaboration level. However, I think it's helpful to see where an organization may progress in terms of a level 1 to a level 6. That's kind of why I like this tool, because you can see sort of the goals that you might establish to advance across the levels here. So level 2, it looks a little better, right? There's still separate system. There's more proactive communication though. Communication may be driven more by the individual's needs, so the patient at the center or the client at the center. They may meet, pretty infrequently, but they do meet as community providers to talk about the patient or the population that they're working with. And there is an appreciation or understanding of the different resources and services that they may provide. So these are organizations at a level 2 where that basic collaboration sort of at a distance really fall. Level 3 and 4 are really the co-located providers. Now, I mentioned earlier, you can be doing integration and still have co-located organization. In fact, that's mostly what we see. And that is because of the way that healthcare is financed and the way that there's a divide still, as I mentioned, between physical health and behavioral health. And, some of the policies that we have in place still very much warrant a division in the way these services are provided. So we are, hoping to change some of those things like billing for primary care and billing for behavioral health services. They look very different. And so, if we were to truly achieve integrated care, there would be reimbursement that really is available to reimburse on this comprehensive care approach. And really, it's hard to get to there without having grants and other things that are piecemeal together to support the integrated care work. But at level 3 and 4, this co-location, this is still usually organizations that are working together, so not under the same sort of roof. They may have separate systems, so things like EMRs, but they know how to use them to communicate, or reports that they need to communicate about a population health need. They'll communicate regularly, meet regularly. Like I had one organization that met with their community providers every Friday morning for a huddle. It was all over Zoom, but they met to check in on the patient, the caseload that they had, and they had conversations about, care pathways and things that were needed for the population that they were working with. Their collaboration is driven by, what's needed for the individual and what is known in terms of trusted referrals, adequate referrals. They're using data to track the outcomes of the care that they're providing. They understand, these co-located providers understand the need to be part of a bigger picture and to collaborate with other community providers to address sort of these social determinants of health. So we like to say that organizations that are in a level 3 and 4 are achieving integration. They're just achieving it in a way that works with them in terms of possibly being in separate locations, but collaborating effectively. I'm just reading the chat. I'll get there. So integrated care, level 5, 6. This is, care teams live in the same space. They use the same tools. Both, let's say, behavioral health clinicians and primary care, family medicine are able to access the same EMR, pull out the same information, for example. They are communicating effectively. They've figured out ways to have these regular meetings around the population health. That's part of their policies and procedures. They provide adequate training to their care team routinely around providing care and comprehensive care. There's policies and procedures that the organizations have adopted that really support integration. And really, the culture is blended. You walk into this organization and not know the difference between the care team and their roles, because everybody is working together on both sides of the spectrum, right? To address the physical health needs as well as the mental health and substance use and community needs, addressing social determinants of health. There's trauma-informed care mechanisms in place, adequate referrals. This is what you would see as like that perfect model of integration. There, I haven't seen a lot of these. You probably know of like the Cherokee model. That's a model that's been successful. They started as an FQHC, then they changed to a community mental health center. They have built off of grant funding into a more sustainable funding model within their community. So I think that there are these sort of models that have achieved a level 6, if you will, but there's not very many. And if you think about the Certified Community Behavioral Health Clinic demonstration, the CCBHC, that is not really advocating for an integrated care model. In fact, integrated care is not even a requirement, and that's one of our biggest gripes of the model, but we are certainly working toward developing certain metrics for CCBHC to include that will help with this integrated care piece. But CCBHCs are really looking toward this co-located model of care. They're required to have partners with peer-run organizations, for example, if they're not adopting their own peer specialist model. They're partnering with, other partners through their, I think they're called DCOs, they're designated collaborating organizations. They're required to partner with DCOs to provide this comprehensive care. So it's really a co-located model, but it's one that I think is working really well. And I'm excited about that. I do think that these CCBHCs that are becoming FQHCs are trying to do that so that they can achieve more fully integrated and just have more resources, right? We're seeing what I would love to study is this blending of funding between HRSA and SAMHSA and breaking down some of those barriers at a government policy level. In my spare time, I should probably study some of these CCBHCs that are becoming FQHCs because it's a really good strategy, right? If you can go through the administrative hurdles of applying to become an FQHC alongside your CCBHC work, then you could advance on these levels of integrated care, if you will. Move to the next slide. I can provide a little information about the IPAT tool. I think this is a really practical tool that you all could use if you haven't already applied that. It was a tool that was developed from the levels of integrated care to be sort of a decision tree for your care teams to really look at and assess where you're at in the levels of care, and then to develop goals around where you want to be related to the 6 levels of integrated care. I think I have a slide on the next slide, which is the decision tree. It's a really simple tool. I've done this work with a lot of organizations and teams where you really, you're sitting down with organization, and I just have to say bye real quick to my children. Okay. There. Okay. Back to the letter. So sorry. Okay, so the way this decision tree works is you would sit down with your organization, your care team, whoever that is, that could include community providers as well. And you would simply just walk through these questions, and it's a decision tree. So the first question is, are behavioral health and medical providers in physically or voluntarily one facility or virtually one facility? We're seeing much more virtual co-location and collaboration currently. And then if you answered no, you would just cycle through this decision tree. If you answered yes, it's likely that you're more of a co-located or integrated. So on those level 4 through 6 on the levels of integration. And then you would just go through this decision tree to really land at where you're at. And then you would develop goals. The full tool, and I'll provide the link in the chat in a moment, the full tool has recommendations for wherever you land on this decision tree, what goals or what aspirations you should have to cycle up on the levels of integration or through those cycles. Like if you're a level 4, what do you have to have in place to achieve the next level, which is a level 5? I like this tool because it's really practical. As you can see from this decision tree, it's very simple to walk through this. There's a lot of online tools that you links that you can link to this tool for free, and you can actually just fill it out online, like bring it up on the screen if you're in a Zoom meeting, and just do this in live time. And then some of the links will just automatically populate some goals that you can work toward to achieve the next level of integration. So I encourage you all to look at this tool. Again, I think it's a good starting place to really look at kind of where you're at and where you want to be and what goals you want to achieve to cycle through the levels of care. And I think the next slide and probably the last is on the GHI framework. So this is the tool I mentioned earlier. Like, we've come even farther to develop a more comprehensive tool. This is, you can access this online as well, and I'll just make sure that I send the links to all these resources to you all so that you can have them, or to the moderators so that they can send them out for us. So Montefiore is an organization in New York. Dr. Henry Chung is a psychiatrist who has done a lot of work in integration, and he developed the general health integration framework. mostly his motivation around developing this was around the limitations that are in place with the 6 levels of integration. What he was hearing in his feedback with providers is that it's limited in its ability to address these community partnerships and to require that and the social determinants of health as part of the work. So he wanted to take a more sort of public health approach to integration and apply that in the GHI framework. Again, it's a very practical tool. It has domains that organizations should focus on in terms of their integration work, things like screening, referral to care, and follow-up. So evidence-based screening, evidence-based care for prevention. So it really takes a broader look at the importance of prevention and early intervention as part of integration. It looks at ongoing care management, so that piece around the importance of care management, community health workers, peer specialists. And the framework provides recommendations in each of these domains. The other domains are self-management support, multidisciplinary team-based care. So I talked a little bit about team-based care, and that can include a lot of different community members as part of the team. Linkages with community social services, spiritual services, and how to create effective partnerships with these community providers. And then it really looks at sustainability. So how do you achieve integration without grant funding, basically, and recommendations around what to consider around sustainability. So this tool, to me, I think they're all helpful to understand, also to understand the background of how the tools were developed, but then to apply different elements of these. And if you look at all 3 tools, the Doherty model, 4-quadrant model, the levels of integration, and then the GHI framework, and you kind of study them a little bit, you will notice how they've evolved to a more sort of population public health approach, which is really what all the work that you're obviously doing, because you're not just behavioral health and primary care providers on this call. So you already have the model in place around a population health focus. And so just applying different elements of the tool would be my recommendation. Start with the iPad, look at the iPad, do the decision tree if you haven't done it. See what goals it recommends for moving from a 4 to a 6, and then cycle into the GHI framework. It's a very simple, pretty quick tool to read, but sort of take all the elements that you have from the iPad and the GHI domains, and then create this sort of implementation or work plan that you want to put in place for your organization with. And so that's kind of like, as I think about these 3 tools and how they are threaded together, like that's how I would, how I would approach the 3 tools and how they work together, and then appreciating sort of the evolution of these tools. And how it really matches like the changes that we've seen in the healthcare space and will continue to. I will say that the GHI framework was originally developed for primary care organizations wanting to integrate behavioral health services into primary care. So again, like it started there, but now Dr. Chung has released a tool that looks in all directions. So it's not just limited to being a tool for primary care. Which is great. I think that was a step in the right direction. So my next steps will be to send all these resources that I mentioned. I think the iPad online tool will be really important for you all. And then I'm happy to answer any questions. I know that we're short on time, but we have a few minutes. And I'm also always available via email, phone calls. I still like to talk on the phone, so you can always reach out to me that way too. I did see something in the chat about E&M. With new E&M guidelines, social determinants of health can make an impact on the level of provide effort. Yes. So I think we're seeing a lot of work, advancements in policies and financing supporting social determinants of health, trauma-informed care, the ACEs work that I talked about. And I think a lot of that, we're seeing different sort of awareness around, issues surrounding behavioral health due to the pandemic. And, that's never great that we have to get to this point to really shine a light on the importance of, adequate, accessible mental health and substance use services. But we are at this pivotal point where we can transform policies, and sustain things like telehealth and make sure that those policies are in place for continued care. We just have to, sort of activate around what those recommendations are.
Do we have your email address? Or is it on your slide deck or is it in your?
Let me put it in here for you.
Great, thank you.
And the good thing about the work that we do, just so you all know, we have several centers of integration. In fact, we were just funded, we were awarded the TA Center for PHCs, but we also have a TA Center around integration. It's called the Center of Excellence for Integrated Health. And the team that leads that, the woman who's the director for that technical assistance center, comes from a large CCPHC in Pittsburgh. She's amazing. She understands all things clinical intervention related, but that team provides free technical assistance basically to anybody that requests technical assistance. Our audience, it's rare for SAMHSA, is anyone who's interested in learning more about integrated care. So you could, if you had a team meeting and you wanted to recruit this team to help do a strategic planning session, they could do it for free under the umbrella of the TA Center. So, our work doesn't have to end today in this short conversation. We can continue to provide support for free, which is unheard of. So you can email me and I can get that set up. Other questions related to the tools specifically? I know that that's what you all wanted to learn about.
Bria, I had a quick question. So I know you talked about the tools in the context of measuring it from an individual organization, and I think that's really helpful for all the folks on the call, but I think sometimes we also have conversations on just where we are with integration on a county level. So is there a way that these tools can be used to measure it on like a large scale like that?
Hi, Madana, good to see you. Yes, absolutely. Like we worked with state organizations, public health organizations through our work with the PGHAC grantees that I mentioned earlier. And it's really, you would do the same thing. I would encourage you all to, just as you are today, get together with all of your community providers and involve state leaders as part of that, and go through, for example, the IPAT tool together as a collaborative and identify tools at a county level or even at a state level. We did a lot of that work in Colorado when we were looking towards sustaining SBIRT after the grant ended. We got together the insurance commissioner, the public health department lead, the substance use authority organization, private insurers. We brought all kinds of people to the table so that we could develop unified collaborative goals across at that point, it was at the state level. But you can absolutely take these tools and apply them to the county level, to the state level, or to a committee level even. If you have a committee of public health providers or peer providers, you can also use the tool to develop goals. And you would do it the same way. You would just broaden the scope of it.
Very cool. Thank you. Good to see you too.
Well, I know that we are on time. I just want to thank you all for your time today and inviting me here. And I would, again, be happy to answer questions, also to explore TA opportunities for you beyond today. So more than happy to.
Yes, thank you, Bree, for coming on. This was really, really helpful, and we truly appreciate it. Before everyone jumps off, I'm not sure if Scott is still on the call. He may have had to jump off, but I want to let you know that we renamed our group. This small committee now is going to be called the Behavioral Health Integration Group. And we meet on a monthly basis, and we want to invite people that are interested in working with this team to help organizations in Prince George's County become integrated. So if you're interested in this type of work and you would like to join this committee, we have your names, and we will. You can see in the chat. You can email Megan Sontag, and her email is right there. And we will reach out to people who registered, just to let you know, we meet on the first Thursdays of the month from 2:30 to 3:30 p.m. And again, we come together and we talk about things such as integration and how can we move organizations to integrate and how can we meet people to collaborate. We wouldn't have been able to get our CCBHC without this group and meeting people to be able to collaborate to do the work that we do. So it's really key. So we really encourage you to join in and hope to see all of you at our next meeting, the first of the month. So thank you so much.